So I want to show you three cases, case examples, and I want to explain you my different strategies, what I have. So here it's the first case, it's 21 millimeter perimount in a lady, and we have the valve-in-valve app, and we looked there, what is the recommendation and what is the true inner diameter of this 21 valve. So stent inner diameter is 20 and true inner diameter is 19 millimeter of this valve. So when you have this small inner diameter, then it's predictable that you will get a mismatch when you do valve-in-valve therapy. When you do CT measurement, then, because there is also pannus and calcification in the leaflets of the valve, then you realize the valves, or the inner diameter, true inner diameter, is even smaller. So in this case, it is shown the root. Why? Because this I take into my consideration what to do, because you have two options. You can crack or fracture the surgical valve beforehand or after implant of a transcatheter valve. And so look at this root. When in the root you don't have a lot of space, then it's not a good idea to fracture and to make the surgical valve much bigger, because then you are in risk to have a root injury or a root rupture. So here, as the sinus are tight, or the space in the sinus is tight, the strategy, what I preferred was implant a valve first, in this case a 20 millimeter sapien. You have to, in my opinion, you have to use a balloon expandable valve as a good radial strength really to get a good result after fracturing. Why? Because with self-expanding valves you can fracture, but the self-expanding valve radial force, it's not strong enough to push the frame out of the way. So here, as I told you, the concept was 20 millimeter sapien 3 at this time. Now we have sapien ultra. So implant valve first. And you see here it is good deployed but not complete. It does not touch the frame. So you have some more space. And here you cannot use a too big balloon, otherwise you destroy the transcatheter valve. In this case, we used a 20 millimeter true dilatation balloon. Remember, the surgical valve 21 perimount has a true inner diameter of 19 plus the valve frame of the sapien. So you have you do a lot of oversizing with a 20 balloon. So this is a 20 balloon, and there was a burst pressure of 16 atmosphere, so something happened with 60 atmosphere. What we realized, there was a pressure drop that usually you realize when you put in the fluid into the syringe, and up to one pressure point, you have a drop of pressure. So what can happen? The balloon can rupture or the frame ruptures. Sometimes you hear something like when you crack a nut. But it's not very often. It's a popping sound. Afterwards, you see then an effect in hemodynamics, in echo or in invasive measurement. Up. So this was then the acute result. You see that the sapien looks a bit bigger, and the valve itself is still patent. In Kasel we saw no gradient afterwards. And what is important, also next day when the patient came in an echo lab, we had also no gradient. So often you see when the patient laying on the Kasel lab table, you see in a Kasel lab no gradient. Next day in the echo lab, it's complete different. I think when a patient moves, it activates the circulation, and then you have a different situation. But here, a very accepted result. And what we saw in CT afterwards, what happened with the valve frame, this was before and this after, and you see clear that the frame is ruptured at different points and that the inner diameter became bigger. Second case, let's continue fast. Here I want to show you a case, also 21 perimount, treated here with a self-expanding valve, with a core valve. So here it's a core valve implant. So the other concept is supraannular valve, lower gradients because the supraannular place of the valve, and that you don't lose space in the surgical valve frame. So this is the result. I don't know if somebody sees something not good. I will show you. The next day what was not good, we saw there was a high gradient. Even the gradient in the Kasel was not this high, so invasive gradient. And then I looked again at the result, and I saw the frame was not completely deployed. And I think this will happen often when we do a treatment with a self-expanding valve, a valve-in-valve, that the valve is not full deployed, and then you create something like a neo-outflow tract obstruction. Here this is your neo-outflow tract, and when it's not complete deployed, your problem is here and not there. So what we did also here in this case is CT to understand it better, and you see the valve at the inflow is not completely deployed. We brought the patient back in a cath lab. We post-dilated this also with a 20 millimeter true dilatation balloon. And we got this result. And you see here, now the frame is better deployed, but what happened also, the valve became a bit higher. So you can dislodge also when you do this technique. The gradient became better, but not perfect. So this is a comparison. So it is not, I'm not sure what is the best option for this kind of patients. Is it a self-expanding supraannular valve? Is it an intraannular valve with fracturing? Here I want to show you a very special case. That's my last case. This is a case where the patient had, it was a man, a 21 perimount also, but the valve, he came back with a high degree valvular insufficiency, paravalvular insufficiency. And you see here it's a non-coronary site that the valve is not, it's partially detached from the annulus. And so then this is how it looked like when we did the root chart. You see there is a high degree insufficiency. And here we did a CT and we realized that it was a 21 valve implanted, but the annulus was much bigger. The annulus mean diameter, what we measured directly under the, below the valve, perhaps the upper outflow top, was more 24 millimeter in mean. So that means here a bigger valve would be the adequate option. And so what to do with this kind of patient? So there were two options. One is placement of a plug here and do a valve-in-valve to treat insufficiency and also the failed surgical valve. Or the other option, what I thought, is to crack the valve frame first. But in this situation, we have a lot of space in the root. So here, in this case, in comparison to the other case here, we can win a lot of space. So here, fracturing, in this case, the 21 valve that we are sure with a 22 millimeter Atlas gold balloon. Remember, we can give here 25 atmospheres, and the frame fractured at this point. And then followed by a 26 millimeter valve. So usually you take a 20 millimeter valve. Here it's 2 times bigger. And we placed the valve more towards the ventricle to flare the bottom to get a better sealing in the outflow tract region to solve the problem of the paravalvular leak. And then in addition we post-dilated with the 26 valve a 24 balloon to win more space. And that it's how it looks like. So you see the inflow is flared. It's a bit more towards the ventricle. We could get a good sealing of the outflow tract with this. We could fix the valve and we could replace the surgical valve And here's the CT afterwards with the fracture. And here you see the results before and afterwards. Okay. Let me. It looked better afterwards, but you see it here. Okay, so what are the limitations of this treatment? You have perhaps there's a question of increased stroke risk of when you dilate surgical valves. The balloon can rupture while you treat the valve. You can dislodge the valve. You can have an annular rupture when you have a small native anatomy, and of course, you can damage the leaflets when you do it after a valve implant. But as you know, this kind of patients are very old often, and I don't take care of damage of the leaflet, what will perhaps ends in a reduction of durability of 1 year. That's not a big topic for this patient. When you want to read about strategies, we publish this also. Yeah, that's my last slide.